Greetings to everyone. I, Dr. Chaitali Chaudhary, welcome you all to Physio TV. Today we are going to have a webinar on assessment of Asia scale in spinal cord injury by Dr. Dinesh Chavhan. I would like to welcome Dr. Dinesh Chavhan. Sir is MPT in Neurosciences, PhD scholar MUHS from SET GS Medical College, Associate Professor in Sancheti College of Physiotherapy. Sir is certified in ICNFA, PNF therapist. Sir is also certified in aquatic and NDT therapy. Sir has more than 10 research papers in national and international journals. I welcome you, sir, and hand over the session to you. Thank you.
Thank you so much, Dr. Chaitali, for giving a wonderful introduction. So we'll move to our topic. Okay, so today we are going to discuss the most important scale used in spinal cord injury, that is American Spinal Injury Association scale, that is ASIA scale. So as we know that ASIA scale is widely or all over the world is acceptable scale to use in the spinal cord injury to find out the level of injury. Okay. So as we know, the scale look like this. So if you see the right quadrant and left quadrant of the scale, so right side what we are the quadrant we see the motor assessment for the key muscle. So for the upper limb 5 key muscle, for the lower limb 5 key muscle. Then for a sensory assessment, if you see from C2 to C2 to S4 S5 level, so here we are going to see the light touch sensation assessment and pinprick sensation assessment for both the side, your left and right side. So according to that, there is again a given how to grade, what are the grades for a sensory, what are the grades for the motor assessment. So then you have to summarize at the end how much the score the patient had achieved, and that according to that you have to add sub score down. So then you come to know the neurological level, and there the neurological level of injury, complete, incomplete, ACI impairment scale, and zone of percept preservation. So in a brief, you see all the assessments. So now we'll go in a detail how to assess. So in the math, in the scale is given how to assess in the motor scale, like as in a motor assessment as a MMT wise 0 to 5 grade, and then NT that is non-testable. Then sensory how to grade 0, 1, 9, 2. Then what are the key muscle to assess it? How you score the ACS impairment scale. Then what are the steps for the classification, and how to check for a zonal participation. So we'll see detail. So use of ACS scale is to find out the neurological assessment. So what the level of, then determine the level of injury. What is the level of injury? We come to know when we assess the ACS scale. Then track the progression of the recovery. So we can use this scale when we assess the first. So on the basis of assessment, we determine that what is the level of injury. Then when we treat the patient, so after some time again we can see, again we test the ACS scale and we know that whether the patient is progressed or good or not. So we can use to track the recovery of the patient. As a diagnosis purpose, yes. So whether when we test the scale, we come to know that according to ABCD grade of the patient, yes, whether it is complete or incomplete cord of injury. So these are the uses of spinal cord ACIA scale in spinal cord injury patients. So if you see what are the steps for classification, so there are determined sensor level for the right and left side. Then determine the level of motor, again level, again the left side what is, and right side what is the level of the lesion impairment. Then determine the neurological level as a whole, both sensory and motor level of the injury. Then determine whether the injury is complete or incomplete. And yes, according to ACI impairment scale, we know that what is AI as the grade. Okay, so that also we'll see. So sensory level, how to determine or perform the sensory level. So sensory level is determined by performing an examination of the key sensory point within each side of the body, right side, left side. So the most caudal, which is normally innervated dermatome for the muscle that like pinprick and your light touch. Yes. So for this, you should know what is the dermatome, where is the dermatome, and how to test the dermatome. So this may be different for the right side, may be different for the left side. So it's very good that we come to know that what is the level of right side, what is the level of left side. So in a brief, we know that how much the level of the patient has the lesion. So where how much the patient have preserved the sensation, that is normal the sensation, whether it's pinprick or light touch. So if you see for the motor level, so motor level is determined by examining of a key muscle. So key muscle for the upper limb. So we are in a brief again 10 myotomoid muscle we are going to assess here for upper limb C5, C6, C7, C8 and T1 level. That is the key muscle we are going to assess here. So according to the MMT, we come to know that how much the grade. So according to that, we have to see. Then is defined by the lowest key muscle of the function that grade at least the grade 3 of MMT. That key muscle function represent that segment and above the level are judged to be intact. So if it is grade 3 MMT of that muscle and above their level is completely more than grade 3, then we come to know that yes, this a motor level is what is the motor level of the patient, the level of the impairment. So if you see the neurological level is a combine of both your sensory and motor. So most caudal segment of the spinal cord with the normal sensory and again a motor function by your anti-gravity muscle, which is preserved for both the side that provide there is a normal sensory and motor function study. So if you assess and you come to know that yes, this is the level where the above there is a normal, okay, sensory that is grade 2 and again for a grade 3 or more than grade 3 for motor. Then we can call it as a neurological level of each. If you see the component of the test, what are the component we have tested here? So light touch sensation by cotton, pinprick sensation by the pin, the sharp end we use. Then manual muscle testing by using MMT grades. So these are the components we test during assessment of our ACS in spinal cord injury. So if you see the determine the sensory level for the right side and for the left side. If you see on the there is given a diagrammatic presentation that how and where to test the sensation. If you see that dark point is where actually you take the check the sensation there. So if you see the grade, then 0 is absent, grade 1 is impaired sensation, grade 2 is a normal sensation, and NT that means not testable. That you can write as a NT. Okay. So if you see bilateral, the dermatome, you have to test bilaterally from C2 to S5 level. Okay. So if you see light touch with the wisp of cotton, apply lightly, do not stroke, okay, across the skin exceeding again 1 centimeter should be pinprick You have to use the pin when prick with the light pressure without moving pin after that point. So that point is very important where you are assessing. So if you see the diagrammatic, there is given representation that where you have to test actually. So now in the next coming slide, we'll see that how we check actually. Okay. So sensory grading again. So C2 to S4, S5 level, the light touch for a right side, for a left side. Pin prick for a right side and left side. Again, you have to grade according as we have discussed already absent, impaired, that is partial or alter. Okay. Then if you see it's given in the scale, these are the column. So you have to fill that column with the appropriate grading of the patient in the test. So now we'll see the video of the assessment, how we do a sensory assessment. Hello all. Now we'll see the testing of sensory assessment in spinal cord injury patients. So there are two ways we check the sensation. First by with the light touch and next is pin prick. So light touch by the cotton whisper. So position of the patient is supine lying. Okay. So now I will ask my model to close the eyes. So whenever you feel, let me know. Okay. So according to my dermato-wise, we'll check. So we'll start with the. If you see patient position supine line, and then I am testing with the cotton whisper of the cotton patient to see yes or no. Now C4. So according to dermato-wise, this is for C5. Now, this is for C5. Bilateral. Now, this is for C6. Now, C6. Okay. So C7 now. Now, good. C7 now. C8 now. C7 and now C8. Good. Now for a T1 now. Now T2 now. Now T3 for T3 start the level of nipple will check for a layer sensation. T4 like this for the now test now T5 now T6 now T7 now 8 now T9 now T10 now T11 now T12. So L1 at the middle of the thigh groin region. Now so not expose the now part now near to genital area. So there actually you have to test for L1 sensation. Now so now we'll test L2, L3, L4. Now L4. Now L5. Now S1. Posterior part now yes. So like this we test the light touch. Okay. Now we'll start with the pin prick. Again the same dermatome will check by the pin prick. So you will feel like the pain. Okay, when I light touch with the cotton. Close the eyes. So now we'll test the pin prick sensation with the now pin. Now same dermatome will follow. Now this is for C4. Okay. Now C5. Now C6. Now C7. Now that's 7. Now C8. Now T1. Now T2. Now at the nipple level, if you see, so T4 level we are testing. T4. Now every time we have to ask the patient how you feel, whether you feel yes or no. Now T7. Now T8. Now T9. Now T10. Now T11. Now T12. Okay, so this part is not exposed, so we will move till TL2 now. Now the pin point has to be touched only, not to be touched the other part. So that's why you have to take care of it. Now L4. Now 5. Now S1. Now S2. And at the sacral region, S3, S4, S5. The genital so like this we have to test the light touch and pinprick sensation. S3, S4, S5. Scale. Thank you. Yes, so like this we have to test the sensory assessment for the spinal cord injury patient for when we are assessing a ASIA scale. So if you saw that, so both sensory by a light touch and pinprick. So at one go you have to test both, so we come to know that whether the sensation is what level till the patient has sensory preserve, and from there where the patient has sensory loss. So we come to know that which sensation, what level is present. Okay. So sensory assessment for the anal region, again C4 and C5 S4 and S5 dermatome, you have to take the perianal sensation, deep anal sensation. So we come to know that. So whether it is preserved or not is under the precaution, and take the privacy of the patient and take consent of the patient when we expose the part. Yeah, now to move towards determine the motor level of the right side or the left side. So here the key muscle is given for 5 key muscle for the upper limb and 5 key muscle for the lower limb. So in a brief, if you see for the upper limb, right side or left side, you have to check. Okay. So if you see C5, that means you have to test for elbow flexor muscle. Then according to that, you have to grade. Then wrist extensor muscle, C6 myotomy, then elbow extensor muscle, C7 myotomy, finger flexor muscle, and finger abductor, little finger. So that is T1 level. So that we have to mark according to the patient strength, like 1, 2, 3, till the 5 or not testable. For lower limb, key muscle, the represent against segment L2, that means hip flexor, L3, that means knee extensor, ankle dorsiflexor, L4, long toe extensor, that is your EHL muscle, actually we are testing L5, then ankle plantar flexor muscle, S1. So according to that, we have to grade, and then WAC is nothing but a voluntary anal contraction of the muscle, yes or no. So how you have to grade? So manual muscle testing grading, you have to do according to the 0 to 5, that is total power less than 0. 1 is palpable or visible contraction grade. The 2 is active movement, a full range of motion with a gravity eliminated plane So see to it that the range has to be completed. Then grade 3 is active movement, full range of motion against gravity. So you have to place in a such a way that the movement will happen against gravity and it has to be complete. So grade 4 is active movement, full range of motion against gravity. You have to use a moderate resistance or it's called a sub-maximal resistance. Grade 5, active range of motion, full range of motion against gravity, full resistance, or it's called as maximal resistance. So these are the grade you have to do according to the patient taking the against the gravity when we are testing a motor component. So other consideration here you have to take the grade must be achieve full range of motion at the given resistance. Then if it is not testable, then you have to test that yes, say that NT that not testable could be not be testable due to the pain or cast or fracture that you have to mention or no pulse or the minus. Here you have to use no pulse or minus. So now we'll see how actually it is. So we have a videos of it.
So now we'll see a motor assessment of Asia scale. So in motor
Sitting
assessment,
position
upper
for
limb
the
we
upper
have
limb,
5 key
muscle
muscle,
testing,
lower limb we have 5 key
5
muscle.
muscles.
So we'll assess according to the myotum wise. So for myotum wise upper limb C5 myotum. C5 myotum is elbow flexion. So okay. So now you have to bend like this. Okay, bend. Yes, so this is grade 3. Now I'll
So
apply
grade 3
resistance
for
up.
C5, bicep,
Grade 4,
elbow
I'll
flexor,
apply maximum resistance up.
and
Grade
maximum
5.
resistance,
So this
grade
is
5.
C5. Next is C6. So C6 is myotum is wrist extension.
Supported with the
So
support
from here,
and then after
it up,
to perform this
up.
up.
Grade 3. I'll apply resistance. Grade 4. I apply maximum resistance. Grade 5. Okay. C6. Now C7. So now C7 is a myotum of elbow extension. Okay, tricep. Lift up like this. Up. Grade 3. Now I apply resistance up. Grade 4. I apply maximum resistance. Grade 5.
Gravity,
Okay.
4 and
C7.
5 grade.
Now
Then finger
C8.
flexor.
So C8 is finger flexion. So do finger flexion bend. Okay. Grade 3. So now I apply resistance. Take up. 4. I apply maximum resistance. Take up 5. Okay. C8 is done now. T1.
Abduction.
T1 is finger abduction. Open the finger. Yes.
Review resistance.
Now open.
For little finger for abduction.
Open. Fine. Okay. So this
for
was for upper limb key muscle.
Limb 5
Now
key
we'll
muscle.
see lower limb key muscle.
Motor.
So lower limb key muscle L2. L2 will be a myotum for hip flexor. So now hold like this. So do this.
Now for L2, flexor muscle.
Up. Grade 3. I'll apply resistance up. Grade 4. Up. Grade 5. Okay. This was L2. Now L3. L3 is knee extension. L3 myotum knee extension. You perform grade 3. Now I'll apply resistance. Take up. Grade 4. Now I apply resistance. Up. Maximum grade 5. Okay. Next is
L4. That is
L3 is done. L4. L4 is ankle dorsiflexion. So in this position, take up. Yes. Take up. Grade 3. I'll apply resistance. Take up. Grade 4. Grade 5. Okay. So now L5. L4 myotum is your
5
extensor hallucis longus. H. Take up.
muscular muscle.
Take up. 4. Take up. 5. So now S1. So this was for your 5. S1 is a plantar flexion. Can you go line, prone line down? So in prone line is a plantar flexion S1. So now if you see like this, take up, up.
So plantar
Grade
flexion
3. I apply resistance from calcaneum. Take up. Grade 4. Take up. Grade 5. This was for S1 plantar.
Yes.
So this was the lower limb muscle MMT of key muscle. Thank you.
Okay, so this was all the MMT, that means 5 key muscle upper limb and 5 key muscle of lower limb we have assessed the motor component according to my term. So how to grade, where to write? So if you see that circle is given the right side where you have to mark according to the scoring of the muscle. So grade 0 to grade 5 and non-testable if it is. Okay. Then reason mentioned. So C5, C6, C7, C8, T1. So you have to fill up that. Then for the lower limb muscle motor component, you have to fill up L2, L3, L4, L5, S1. So 25, 25 plus is equal to 50. You have to mention according to that how much the patient has the 50. Grade 4, the 50 on the right side and left side again you have to calculate the 50 score. So according to that you have to write down. Okay. Next is like the sensory. Yes, according to the 0, 1 and 2, that is total your 56. Pinprick 56, light touch on the right side and the left side. According to that you have to fill in that box. And then if you see the motor component, upper limb and upper and lower. So 25, 25 left side, the motor component, then your sensory component. So if you look here, you come to know that where to feel the lower limb MMT, where to feel upper limb MMT, then you have to mark according to the total score of the 100. So if you see, this is the sensory score where you have to mark separately. Total score are calculated for left side, light touch and pin prick, and the left side and right side. According to that, you have to mention, then you have to summarize after 56 plus 56 is 112. Okay. So how much the patient is the score. So ASI impairment scale classification, according to that, we know that determine the sensory level of the right side and left side. The lowest level with the 2 is a normal for both the pinprick and light touch, where every level is higher is like 2. So according to that, you have to fill this form: sensory for right, sensory for the left. Then for the motor, determine the motor level of the right side and motor level of the left side. The lowest level where the muscle grade is at least of grade 3, then with all the muscle above has to be a grade 5. Then you can write a motor component level for the right side and motor component level for the left side. Then at the end, you know that how much is the sensory level, how much is the motor level for the right side, how much is the for left side. So determine the neurological level of the injury, the highest level of the 4 individual level you can say, and then you will say that yes, neurological level of the injury for both sensory and motor. You have to conclude that yes, this is the level. If you see about T6 is the normal sensory and motor, then you can calculate the T6 level of injury. Okay, neurological level of injury. So here you have to mention that determine whether the level of injury complete or incomplete, that defines on the basis of complete injury or incomplete on the basis of your voluntarily anal contraction, whether it is normal, okay, or deep anal pressure which is normal, and sensation preserve S4 and S5 level. So that defined by the presence or absence of sacral sparing. If no voluntary control, voluntarily anal control contraction, then you can call it S4 and S5 sensory score, and there is no deep, then you have to write down. Then injury is complete. So no sign if it is present. That means a complete. If there is a no sacral sparing of your sensation, then it called as a complete level of injury. So how you have to grade ASIA scale impairment scale grading? Complete means the below the level of injury there is no sensory that is sacral sparing also not possible, sensor so not possible, motor, that is complete level. So if it is B, that means sensory is incomplete, yes. Okay, motor is not possible, but sensory is incomplete, then you can call it as a grade B. Grade C is motor incomplete. The above level of injury is at least grade 3. So less than, you can say that grade 3 or less than grade strength. It is D, that motor incomplete, that means there are muscle, half the muscle is more than grade 3, that is a motor incomplete. Okay, so E is a normal. So like this we can grade ACI impairment scale A, B, C, E, and so zone of partial preservation. What is zone of partial preservation? Only defined for the ACI impairment scale A complete lesion, and yes, lowest dermatoma and myotoma on either side with any piezo function, even if it is abnormal. If you see, then you can call this a zone of partial preservation. But keep in mind that in the complete injury only. So most caudal level with any innervation patient, maybe a sensory or motor, or okay, right or left side. Then you can feel and you can say that zone of partial preservation. So these are the references, okay, where we have taken from the information. So thank you so much for the listening. So over to you, Dr. Chaitanya.
Thank you so much, sir. It was a very enlightening session. Sir, you explained very well about the ASIA impairment scale in spinal cord injury level. Sir, you explained very well about how we can determine the level of injury in spinal cord injury patients. But I have a question about this. Can we perform this assessment of ASIA in inflammatory or infective etiology of spinal cord injuries?
Okay, so good question, Dr. Chaitanya. Ideally, if you look at the spinal cord injury scale, is mostly made for to know the level of injury. So when there is a traumatic, the cord injury happens, that there we know that yes, there is a trauma. But after a certain time, when we want to find out whether it is a complete cord or incomplete cord. So ideally, to know that what is the level of injury, we do this ASIA scale, that yes, we come to know that this is the level of injury in the motor and sensing. So according to that, we can mark it as it is incomplete or the complete. So that means on the, if it is incomplete, then whether it is B, C, D. Okay. If it is an inflammatory disease condition, it's very difficult to find out the level of injury because it's a widespread of injury, the affection. So ideally, best way is to do in a traumatic condition where the spinal cord injury is damaged, so we know that exact what is the level of injury. Okay. So I guess I answer your question.
Yes, thank you so much, sir. It was indeed a very informative session. You explained each part of the examination and demonstrated it with the video clips as well. I am sure all our viewers would be clear about the assessment of ASIA. I would like to give a vote of thanks. Thank you for Executive Director Manisha Sangvi ma'am. Thank you to Chairman of Sancheti Group, Dr. Parag Sancheti sir. Thank you to our beloved Principal, Dr. Apurva Shimpi sir. Also, thank you to our technical team and Dr. Tushar sir for their constant support. I also like to thank all my viewers and would like to conclude the session. Thank you so much.
Thank you so much.